Welcome to the deep dive. Today, we're jumping into the fascinating world of sedative hypnotic drugs.
hmm
Those medications designed to help us relax, quiet the mind, maybe get some sleep.
Yeah, these are incredibly common drugs, aren't they?
Hmm.
Prescribed for a whole range of conditions.
Right.
But really understanding exactly what they are, how they tweak our brain chemistry, and sometimes surprising differences between them. That's key to being truly well-informed.
Absolutely. And that's pretty much our mission today. We've dug through a stack of sources, lecture notes, textbook excerpts on pharmacology
Good stuff.
to pull out the most important insights for you. We're trying to cut through the dense details to give you the essential knowledge.
Think of it as getting the core understanding without needing that medical degree.
Exactly. So let's unpack this. Our sources, they start by laying out the major players, grouping these drugs into a few big categories.
Right. The material points to basically three main families: benzodiazepines,
Okay.
barbiturates, and then a kind of catch-all group for other anxiolytic and hypnotic drugs that don't fit neatly into those first two.
And they give us some examples, right? For benzodiazepines, they list diazepam.
Correct. That's a classic one. And for barbiturates, a key example they highlight is phenobarbital.
Got it. And then under other anxiolytic drugs, we see buspirone.
Yes. And the category for other hypnotic drugs is actually quite broad. It includes the Z hypnotics like
Yeah.
zolpidem, zaleplon, isoprolol.
Zolpidem, yeah.
It also covers things that work on totally different systems, like ramelteon, which targets melatonin receptors,
Interesting.
disulfiram, working on orexin receptors, and even some, familiar antihistamines like diphenhydramine.
Wow, that's already a really diverse lineup. Okay, let's start with the benzodiazepines, or benzos. Our sources dedicate quite a bit of detail here, suggesting they're pretty central.
Oh, they are. Very widely used. And the notes immediately break them down based on how long they stick around in your system, their half-life.
Okay, so the duration of action is a big factor, how long they last.
Exactly. They categorize them. Short-acting, so a half-life's less than 5 hours. Examples being midazolam and trizolam.
Short ones.
Intermediate acting, 5 to 24 hours, like alprazolam, lorazepam, temazepam.
Okay.
And then the long-acting ones, over 24 hours, including diazepam, clorazepate, and flurazepam.
So that tells us something about, how often you might take them or how long the effects could linger. How does the body actually handle these drugs, the pharmacokinetics part?
Well, the sources note they're typically absorbed quite quickly if you take them orally.
Right.
Once they're in your bloodstream, they spread out pretty widely to all tissues and, crucially, including the brain where they need to work.
Makes sense.
They also cross the placenta and can get into breast milk, which is, an important consideration.
Definitely. So they get right to the brain. But how do their effects wear off if they're spread everywhere?
This is a cool detail our sources mention. It's not just about being metabolized, broken down.
Oh.
For some of these drugs, especially the faster-acting ones, as the concentration in the blood starts to drop, the drug actually moves out of the brain and back into the blood and other tissues. This physical redistribution is actually a major way their immediate effects on the brain stop.
Oh, that's fascinating. It's like they retreat from the site of action. And how are they broken down eventually? Metabolism.
Yeah, they're mainly processed in the liver. And this is where those duration differences really show up again. Our notes explain that the long-acting drugs, like diazepam or flurazepam,
Uh-huh.
are often metabolized into active substances. So the liver breaks them down, but the pieces left over are still working, sometimes for a very long time.
Wow. The breakdown products are like mini drugs themselves. That explains the long action.
Exactly. And the shorter-acting ones?
What about them?
Well, the shorter-acting ones, like alprazolam or midazolam, they're typically broken down into inactive substances. The body then clears these inert products, primarily through the kidneys. So since the metabolites aren't active, the drug's effect is shorter, tied more directly to how quickly the original drug is metabolized and cleared out.
Okay, that makes intuitive sense. Active metabolites keep the effect going. Inactive ones mean the effect stops when the original drug is gone. So the burning question, how do they actually do this? The sources point straight to the GABA A receptor.
Right. This is the core mechanism, and it's one of the most important insights from our sources, really. Benzodiazepines interact with the GABA A receptor. It's this intricate protein gate embedded in the surface of nerve cells.
Like a channel.
Yeah, our sources describe it as a complex made of 5 pieces, sort of surrounding a central channel, specifically for chloride ions.
Okay, a 5-part gate for charged particles. Chloride ions.
Exactly. And GABA itself is the brain's main natural off switch, its primary inhibitory signal.
Calms things down.
Right. When GABA binds to this receptor, it opens that gate, letting negatively charged chloride ions rush into the neuron.
And that inflow of negative charge makes the neuron quieter, right? Less likely to fire its own signal.
Precisely. It hyperpolarizes it, makes it less excitable.
Yeah.
Now, here's the really crucial part about benzodiazepines. They don't bind where GABA does.
Oh, Evan.
They bind to a different spot on this same receptor complex. Our sources are very clear. They cause allosteric modulation of GABA action.
Allosteric modulation. Okay, sounds complex. What does that mean simply?
It just means they bind elsewhere but change how the receptor works when GABA is present. They don't open the gate themselves. Think of them like a helpful co-pilot for GABA.
Okay.
When GABA binds, the benzodiazepine increases the frequency with which that chloride channel opens.
Frequency. More often.
Yes. So if GABA is knocking to open the gate, the benzodiazepine makes those knocks more effective, causing the gate to swing open more often, more frequently.
Ah, okay. So they boost GABA's signal, make it more potent, but they need GABA to be there to do it. They don't act alone. That seems like a really important distinction.
It's critical.
So what does boosting GABA's inhibitory signal lead to in terms of, effects on a person?
Our sources list several key effects. At lower doses, they dial down anxiety, a mild calming effect on the central nervous system.
Okay, anxiolytic.
Right. At higher doses, they promote sleep, acting as hypnotics.
Like using temazepam for insomnia, which I think the sources mentioned as a use case.
Exactly. That's a good example. They also relax muscles centrally
Muscle relaxation.
and have a powerful anticonvulsant effect, which is why IV diazepam is a go-to for severe ongoing seizures like status epilepticus.
Right, stopping seizures. And there was that fascinating point about memory disruption.
Yes, specifically anterograde amnesia. This is a key insight from the sources. It means you won't form new memories of events that happen after you take the drug.
After the drug, okay.
And our sources highlight that this isn't just a side effect. This specific amnesic property is actually useful for procedures you'd rather not remember.
Like what?
Like an endoscopy or maybe a minor outpatient surgery. You're awake, you can cooperate during the procedure, but afterwards you have little to no recollection of it.
Huh. That's a powerful effect deliberately used then.
Yeah.
So connecting these effects to the therapeutic uses, the sources list anxiety disorders, GAD, phobias, panic attacks, but they add a really significant caveat here, right?
Yes, a critical note. While BDZs are effective for acute anxiety or maybe short-term use, the sources emphasize that for chronic anxiety disorders, like long-standing GAD.
Yeah.
Other classes like SSRIs and SNRIs are often the first choice. This is particularly true because of concerns about potential addiction and dependence with benzodiazepines over time.
Okay, so effective for immediate or short-term relief, but maybe not the best long-term solution for everyone. We also mentioned insomnia.
Right, temazepam example.
Short procedures using midazolam, severe seizures with IV diazepam, and muscle spasms or spasticity with diazepam. Those seem like the key uses.
That covers their main applications according to the material, yeah.
Yeah.
Now we should talk about the potential downsides, the adverse effects.
Right. Sedation, memory issues, trouble focusing. Those feel like pretty direct consequences of, increasing inhibition in the brain.
They are. And a major concern our sources highlight is the potential for tolerance and physical dependence.
Okay, tolerance and dependence. How does dependence actually develop? The sources explain the brain's reaction, don't they?
They do. They link it to the brain, attempting to compensate over time. It tries to counteract the drug's effect by decreasing the sensitivity of its GABA receptors,
Making them less responsive.
and at the same time increasing the activity of excitatory systems like those using glutamate. It's the brain basically trying to rebalance itself against the constant sedation.
Yeah.
So when the drug is stopped suddenly, this underlying imbalance can lead to withdrawal symptoms, including rebound insomnia. Insomnia comes back, sometimes even worse than before.
The brain pushing back. And what about that hangover feeling people talk about?
That's especially associated with the long-acting drugs, or those with those active metabolites we discussed earlier.
Right.
The residual drug, or its active breakdown products, can leave you feeling groggy with impaired thinking and coordination the next day. And there's also a risk of respiratory depression, particularly dangerous if given too rapidly by IV injection.
Okay. So if someone takes too much, or maybe for a medical procedure where you need to reverse their effects quickly, is there a way to counteract them, an antidote?
Yes, thankfully. Our sources mention flumazenil. It's essentially an antidote.
Flumazenil.
It works by competitively blocking the benzodiazepine binding site on that GABA-A receptor, so it bumps the benzo off.
Okay.
It's used to reverse the excessive CNS depression from an overdose or sometimes to help patients recover faster after using these drugs for anesthesia or procedures.
Okay, so that's benzodiazepines. Boosting GABA's frequency with GABA present, versatile uses, but definitely concerns about dependence and those long-lasting side effects. Now, let's pivot to the barbiturates. Our sources imply these are, well, older and maybe less commonly used now.
That's generally right, yes. They were much more prominent before benzodiazepines became widespread. The key examples in our material are phenobarbital, which is long-acting, like 6-8 hours,
Phenobarbital.
and thiopental, which is notably ultra-short-acting, maybe 15-20 minutes, often used in hospital settings, anesthesia.
Okay. How do barbiturates work compared to the BDZs? Still GABA?
Yes, they also target the GABA-A receptor, leading to increased chloride flow and neuron inhibition. Similar starting point, but a really fundamental difference in how they influence that channel.
Okay, what's the difference?
While BDCs increase the frequency of the channel opening,
More often, yeah.
barbiturates increase the length of time the channel stays open once it does open.
So instead of knocking more often, they kind of prop the gate open longer?
Exactly. And this difference has massive implications. Our sources highlight that at higher doses, barbiturates become non-selective,
Non-selective, meaning?
meaning they can depress activity pretty much throughout the central nervous system, including those crucial centers in the brainstem that control breathing.
That sounds concerning.
It is, and it leads us to the most critical difference our sources emphasize between barbiturates and benzodiazepines. This is maybe the single most important insight that drove the shift away from barbiturates.
Okay, what is it?
Remember how BDZs need GABA to be there to work?
Yeah.
They boost GABA's effect.
Yeah, the co-pilot idea.
Our sources call this the ceiling effect. Because they rely on GABA, the depth of CNS depression you can achieve with BDZs is, well, limited. It's very difficult, though not impossible, to cause truly profound respiratory depression or death simply by giving more and more benzodiazepines, unless they're combined with other depressants like alcohol or opioids.
Okay, so BDZs have a kind of inherent safety limit built into their mechanism.
Precisely. Now, barbiturates, because they can hold that chloride channel open for a long time, and critically, can even cause some chloride influx, even without GABA being present at higher doses.
Well, they can open the gate themselves without GABA.
Yes, essentially bypassing the need for GABA at higher concentrations. Because of this direct action and this lack of dependence on GABA, barbiturates do not have a ceiling effect.
Their ceiling.
No ceiling.
Huh.
Our sources state very clearly that this is why barbiturates can cause severe, life-threatening respiratory depression and profound coma leading to death at higher doses. There's a much narrower therapeutic window.
Meaning the difference between a dose that works and a dose that's dangerous is much smaller.
Much smaller than with BDZs, yes.
Wow. Okay, that explains a lot about why their use has declined. It's fundamentally a safety issue rooted right there in the mechanism difference. What about how the body handles them, pharmacokinetics?
Also some differences. Rapid oral absorption, generally, though thiopental is given intravenously.
Yeah.
They also distribute widely, including across the placenta and into breast milk, similar to benzos.
Right.
The speed of onset and how long they last is heavily influenced by how quickly they get into the brain that's lipid solubility
How fatty they are.
and how fast they're metabolized. Thiopental, being very lipid soluble, hits the brain fast, but is also quickly redistributed out of two other tissues, contributing to its ultra-short duration. Phenobarbital is less lipid soluble, so it's slower on both fronts, absorption and redistribution.
And our sources mention a really important point about their effect on the liver, something different from benzos.
Yes, this is another key difference. Barbiturates are significant inducers of cytochrome P450, or CYP450, liver enzymes.
Inducers, they speed them up.
They essentially speed up the metabolic machinery in the liver. This can cause other drugs that relax on those same enzymes to be broken down much faster than usual.
Oh, so they can mess with other medications?
Absolutely. It can lead to significant drug interactions. You have to be really careful.
They make the liver work overtime on other stuff. Interesting. So what were their main effects and uses, despite the risks?
Well, they do reduce anxiety, and they are potent hypnotics, our sources put like triple pluses next to that effect. Strong sleep inducers.
Oh.
Thiopental, as mentioned, is used as a very fast-acting anesthetic. Phenobarbital is still used as an anticonvulsant, particularly for generalized tonic-clonic seizures, what used to call grand mal.
Right.
They also cause skeletal muscle relaxation.
And the sources also mentioned phenobarbital for neonatal jaundice, something about babies.
Yes, that's another interesting consequence of its enzyme induction property, though it's a slightly different enzyme, evolved glucuronidase transferase. Phenobarbital induces this enzyme too,
Okay.
which speeds up the breakdown of bilirubin, so it helps treat elevated bilirubin levels, jaundice, in newborns.
Ah, a useful application of that enzyme-inducing side effect in that specific case, and adverse effects for barbiturates overall.
Drowsiness, difficulty concentrating, general physical sluggishness.
Hmm?
Physical dependence is definitely an issue, just like with benzos, maybe even more pronounced.
Sure.
And again, critically, respiratory and myocardial depression, heart and breathing suppression directly tied back to that dangerous lack of a ceiling effect. Plus, that hepatic enzyme induction we just discussed, causing drug interactions.
Okay, so barbiturates open the channel longer, can act without GABA, no ceiling effect leading to higher safety risk, plus they induce liver enzymes. Got it. Let's shift gears then and look at some of the other options our sources present, starting with buspirone for anxiety.
Right, buspirone. This one is quite a departure from the GABA drugs we've been talking about.
How so?
Its mechanism involves acting as a partial agonist at certain serotonin receptors, specifically the 5-HT1A receptors.
Okay, so working on a completely different chemical system in the brain. Serotonin, not GABA. What's unique about it?
Our sources highlight that it's a selective anxiolytic. This means it reduces anxiety without causing significant sedation, hypnotic effects, or muscle relaxation like the BDZs or barbiturates tend to do.
Just anxiety relief.
Primarily, yes. And a major advantage flagged in the sources. It
Okay.
has no potential for drug dependence.
No dependence risk. That sounds like a big win, especially for long-term anxiety treatment.
It is, potentially. The main trade-off, according to the sources, is its delayed onset of action.
How delayed?
It can take 2 weeks or even longer to really feel the full anxiety-reducing effects.
Right.
So this makes it less suitable for, say, acute panic attacks where you need immediate relief.
Right.
But it can be better for chronic, ongoing generalized anxiety disorder, or GA. Our sources also note it's often the preferred anxiolytic choice in elderly patients.
Likely due to that lack of dependence and fewer sedating side effects compared to the GABA-acting drugs, I imagine.
That seems to be the reasoning, yes.
Okay, what about the other hypnotics, the sleep aids, beyond the traditional classes? This includes those Z drugs.
Yes, the Z-hypnotic zolpidem, zaleplon, isoprolol. Our sources indicate these have largely replaced older benzodiazepines, specifically for treating insomnia.
Okay, why the shift? What makes them better for sleep?
Well, their mechanism is related to BDZs. They also work on the GABA-A receptor and enhance GABA's effect, so still GABA-related. But they bind at a different allosteric site than where the traditional benzodiazepines bind.
So, still helping GABA, but plugging into a distinct socket on the receptor complex.
Precisely. And the key advantage our sources point to is their greater selectivity. They preferentially act on GABA-A receptors that contain a specific type of subunit called the alpha-1 subunit.
Alpha-1. And older benzos were less picky.
Right. Older BDZs bind more broadly to receptors containing various subunit combinations, alpha-1, alpha-2, alpha-3, alpha-5.
And why does that alpha-1 specificity matter so much?
Our sources explain that this more targeted action is thought to result in fewer unwanted effects. Compared to older BDZs, Z drugs generally have less impact on the natural architecture of sleep.
Sleep stages, yeah.
They cause less impairment of cognition and memory the next day, and seem to have less potential for tolerance and dependence, although not zero.
Okay.
Because they're shorter action and generally better side effect profile, they're primarily used for patients who have trouble falling asleep. Difficulty with sleep onset.
Ah, so targeting specific parts of the receptor leads to cleaner effects. That's a great example of how understanding these tiny molecular details really matters for drug development. What about Rameltian? Different system again.
Completely different system again, yes. Rameltian taps into our natural sleep regulation. It's a selective agonist at melatonin receptors, specifically MT1 and MT2.
Melatonin, like the hormone.
Exactly. These receptors are involved in regulating our natural sleep-wake cycle, our circadian rhythm, and promoting sleep onset. The main adverse effects noted in the sources are things like dizziness and fatigue.
Okay, working with our natural sleep signals. And suvorexant, that was another one.
Suvorexant works on yet another system, the orexin system. Orexins are brain chemicals, neurotransmitters, that normally promote wakefulness and arousal.
Keep you awake.
Right. Suvorexant is an antagonist, meaning it blocks orexin receptors, specifically orexin 1 and 2 receptors. By blocking the wakefulness signal, it helps promote sleep.
Interesting. Blocking wakefulness to induce sleep, another distinct approach. And side effects.
Similar to Rameltian, common side effects listed are dizziness and fatigue.
Okay. Finally, our sources include antihistamines in this hypnotic section, like allergy meds.
Yes, particularly the first-generation ones like diphenhydramine, which you often find in over-the-counter sleep aids.
How do they make you sleepy?
They cross into the brain easily and cause sedation by blocking H1 histamine receptors. Turns out, histamine neurons in a part of the brain called the hypothalamus actually help keep us awake, so blocking them causes drowsiness.
But the sources seem to suggest they aren't as ideal for sleep as Z drugs or maybe even some BDZs.
That's largely because these older antihistamines also have significant anticholinergic side effects.
Anticholinergic, dry mouth, that kind of thing.
Exactly. Dry mouth, blurred vision, constipation, sometimes confusion, especially in older adults. While they do make you drowsy, these other effects make them less desirable, specifically for treating insomnia compared to drugs that are more precisely targeted at sleep promotion or anxiety reduction with fewer side issues.
Okay, wow, we've covered a lot of ground. The GABA enhancers, BDZs, barbiturates, Z drugs, the serotonin modulator buspirone, the melatonin agonist ramelteon, the orexin antagonist suvorexant, and even antihistamines. Let's try to pull together some of the key comparative insights our sources emphasize.
I think the major historical shift the sources really highlight is that move from barbiturates to benzodiazepines decades ago.
Driven by safety.
Absolutely. Driven primarily by safety, specifically that lack of a ceiling effect with barbiturates making overdose far, far more dangerous than with BDZs.
Right, that fundamental difference in how they interact with the GABA A receptor duration versus frequency, and that direct action versus needing GABA.
Exactly. And then following that, the sources show a more recent trend where Z hypnotics have largely replaced older BDZs, specifically for treating insomnia.
And that's driven by?
That shift seems driven by improved side effect profiles, less hangover, less disruption of sleep architecture, less memory effect, and potentially less risk of dependence, primarily due to their more targeted action on those specific alpha-1 GABA A receptor subunits.
So the big picture trend in drug development here, based on our sources, seems to be towards greater safety and more targeted effects by refining our understanding of these brain receptors.
Exactly. It shows progress. And our sources really reinforce that choosing the right drug isn't just about finding something generically sedating or calming. It's a complex decision.
Yeah.
It has to be based on the specific problem. Is it trouble falling asleep or staying asleep? Is it generalized anxiety or panic attacks? Is it muscle stiffness or seizures?
And the patient too, right?
Critically, yes. Factoring in the patient's overall health, other medications they might be taking, remember those barbiturate interactions and their potential risk for developing dependence. It's very individualized.
Understanding the sheer complexity of something like the GABA A receptor with all its different subunits, and then seeing how drugs can be designed to interact with just specific parts, like the Z drugs targeting alpha-1, that's really quite powerful, isn't it?
It really is. It shows the incredible precision that's being developed in pharmacology, leveraging these intricate details of our neurochemistry to try and get better outcomes with fewer problems.
This deep dive has certainly given us, and hopefully you, a much clearer picture of these widely used medications, highlighting the nuances, the risks, the history, and the evolution based on our source material. It's definitely far more than just a simple category of downers.
Indeed. Recognizing these distinctions helps you understand not just the different names you might see on a prescription bottle, but why a doctor might choose one drug over another for a specific situation.
And that leaves us with a final thought to carry forward, something to mull over. Considering how drugs like the Z hypnotics have achieved more precise effects by targeting specific subunits of a complex receptor like GABA, how might future pharmacological research continue this trend? How might they refine medications even further for conditions like sleep disorders or chronic anxiety?
Yep.
What else can we learn about the brain's incredibly complex chemistry by looking at how these increasingly targeted drugs interact with it?
A lot more to uncover, for sure. Lots of potential there.
Absolutely. Until next time, keep diving deep.